Hello, everyone. Thank you for joining us today for the Funding Opportunity Announcement webinar, Reducing Overscreening for Breast, Cervical, and Colorectal Cancer Among Older Adults. Before passing the presentation over to our speaker, Dr. Erica Breslow, I'd like to provide a few tips for using WebEx so you get the most out of today's webinar. All attendees will be in listen mode only. Please feel free to submit your questions throughout the presentation in the Q&A panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. If you need to view live closed captioning, please see the link in the chat panel. I want to note that today's webinar is being recorded and will be posted online at a later date. We also have a feedback survey. Please take a moment to complete that at the end of today's webinar. With that, I will pass our presentation over to our speaker.
Hello, everybody. I'm Erica Breslow, and I'm a program director in the Healthcare Delivery Research Program here at the NCI, and I'm looking forward to talking to you about the funding announcement, Reducing Overscreening for Breast, Cervical, and Colorectal Cancers Amongst Older Adults. Today's webinar is going to focus on three main areas. First, background about our program within the NCI. Second, a brief description of the funding mechanisms supported by the FOA. And then I'll talk about the specifics of this funding announcement. And finally, I'd like to take your questions regarding the FOA. A note here about the questions. If you have questions about specific aims or grant application details, they'll not be addressed in this webinar, and I suggest you reach out to me via email. And my email address will be on the web screen at the end of the presentation. So now to begin with a brief discussion of where the Healthcare Delivery Research Program is located within the National Cancer Institute. There are 5 extramural research divisions at the National Cancer Institute, and our division, the Division of Cancer Control and Population Science, supports extramural research in cancer surveillance, epidemiology, health services, behavioral science, and cancer survivorship. The Healthcare Delivery Research Program is part of the Division of Cancer Control and Population Sciences and is one of the 4 research programs within the division that you can see here. Other research programs include the Behavioral Research Program, Epidemiology and Genomics Research Program, and the Surveillance Research Program. The Healthcare Delivery Program's main mission is to advance innovative research to improve the delivery of cancer-related care. Our program has 3 branches. In the outer portion of the circle is the Healthcare Assessment Research Branch, and they assess utilization, access, diffusion, and population-based outcomes. In the middle is the Health Systems and Interventions Research Branch where I'm located. Our branch supports research to observe and intervene on behavior and context within healthcare systems. At the core is the Outcomes Branch, which supports research to observe and intervene on behaviors and context where care is delivered. Much of the NCI portfolio consists of investigator-initiated research, that is, unsolicited grants. The NCI and our program also supports grant applications in areas that are deemed of specific interest, and these areas are represented with requests for program announcements, which identifies specific receipt dates, the amount of funds that are going to be earmarked for the initiative, and the number of awards that are likely to be funded. These science received underneath RFAs are reviewed in a special emphasis research, in a special emphasis panel. Program announcements are more general, and such as this one. They are on a specific topic, however, they're submitted underneath the standing receipt dates for NIH, and they are reviewed with all other applications in standard CSR panels. PAR announcements, the R means that it is an announcement with a special receipt date, referral, and/or review considerations. NCI has not used PARs very recently. We usually use RFAs or PAs. Many of you may be familiar with these grant mechanisms, but just to review, the R21 research project grant on the right is the one most common mechanism, and the R21 is devoted to the exploratory developmental grant is on the left. So looking at the R01, the mechanism supports discrete, specified, and circumscribed research projects, and they are the most commonly used, it is the most commonly used grant program. There is generally no specific dollar amount set. However, if you're planning to submit an application with more than $500,000 in direct costs any year, you must contact program 8 weeks prior to receive approval from our division director. And the funding is generally from 3 to 5 years. For the R21 Exploratory Developmental Grant, these applications support new exploratory and developmental research projects. Sometimes they're used for feasibility and pilot studies. The key demarcation here is that they're exploratory and that the preliminary studies are discouraged. Generally, these applications, these grant mechanisms are for a 2-year period, and the costs do not exceed $275,000. Now I'm going to shift to talk about the funding announcement that's the topic of today's webinar, reducing overscreening for breast, cervical, and colorectal cancers amongst older adults. And first I'm going to give you a background on older adults. Currently, 1 out of 7 American adults are 75 years and older. The United States population 75 years and older is rapidly growing, and the use of health services by older adults is placing an ever-increasing pressure on the healthcare delivery system. And in fact, this is the first time in the history people are living into their 80s. For example, a man turning 65 today can expect to live on average until 84 years, and a woman will live on average to 87 years. Looking to the right of this slide, you can see that an estimated 10% of the population will be more than 75 years in 2050, and this number will reach to more than 20% shortly afterwards, and this equates to almost 50 million people in these older age groups. Secondly, there's a significant increase in cancer, which is the second leading cause of death amongst people 75 and older. And thirdly, very importantly, traditionally up until now, anyone who is 75 and 85 years old has been vastly underrepresented in randomized trials evaluating cancer screening, so data are limited about the effectiveness with regards to the harms of screening in this population. There's no single point at which a person becomes older, so age, the number, chronology captures only part of the story, and in fact, the chronology of age is only an arbitrary and inaccurate measure of who really is older in America, and because of the tremendous individual variability in age-related health changes. For example, an unhealthy 65-year-old may be more like a healthy 85-year-old that we see here in this slide. So those of us who work in aging prefer to consider other markers of age, such as life expectancy, functional status, independence, or quality of life. But that said, we're very bound by chronology because of our guidelines. Because of the demographics, this is the right time to focus on older adults to, 1, maximize health and well-being while minimizing preventable morbidity and mortality. Much of the current attention on cancer screening focuses on promotion of early detection of cancer through the initiation of early screening, and less emphasis has been given to screening cessation in populations where screening may be appropriate, conducted more frequently, or in situations where the risk of screening outweighs the benefits. So that said, we need to understand what screening harms may exceed benefits. Over the past decade, the potential harms of cancer screening in older adults have been estimated to exceed the potential benefits, so that the consequences of unnecessary screening are multiple and complex. So that harms from screening may be incurred from screening tests themselves, from the follow-up of tests or diagnostic procedures, or from the cancer treatments that may happen subsequently that may provide little or no benefit because of an adult's limited life expectancy or functional status. Harms more frequently have consequences in older than younger adults, and that they may also aggravate existing functional life limitations. So all of this said, we're focusing on older adults because the screening guidelines have been demarked according to ages, and we felt that this was a perfect opportunity to understand why so many older adults continue to be screened. This slide shows the United States Preventive Services Guidelines for breast, cervical, and colorectal cancers. On the left, you can see that underneath breast, insufficient recommendation was provided stating that empirical evidence is needed to assess the benefits and harms of screening mammography in women 75 years and older, and that patients need to understand the uncertainty of evidence and that routine screening is not recommended for the average-aged women 75 and older. For cervical cancer, the USPSTF provided a D recommendation to discourage the use of cervical cancer screening for women who are 65 and older, who have had adequate prior screening and who are not at high risk. With colorectal cancer, which is on the right, it's a little more complicated. The USPSTF provided 2 recommendations. The first is a C recommendation, which offers selective screening in adults between the ages of 76 and 85 years of age, based on physician judgment, as well as the patient's health and preference. Below that, you can see that there's a D recommendation, which means it applies to adults who are 85 and older, and it discourages the use of all colorectal screening with this group. So for the purposes of this funding announcement, and since the USPSTF is a sister agency, we are following their guidelines to define overscreening as the following: for no routine breast cancer screening in average-age women aged 75 and older, any cervical cancer screening in average-age women 65 years and older, and routine colorectal screening in men and women 75 years and older, and any colorectal screening in both men and women 85 years and older. So in spite of these somewhat recent guidelines, the literature suggests that overscreening does occur. And in work conducted by my colleagues Keith Belezi and Mara Schoenberg, data has been analyzed using the National Health Interview Survey. Looking at the light blue boxes, which represent the older ages, that is, those who are more than 80 years old, it's striking that 50% of women continue to receive mammograms beyond 80 years old, and that with Pap tests are being administered to almost 40% of women. And similarly, with colorectal cancer screening, it continues with almost 50% of the adults. And it's mainly with colonoscopies, which continue with adults well into their 80s in spite of the guidelines that discourage no screening. And these screenings occur because clinicians recommend them, they write scripts for the tests, and patients obtain the test because we know that physician recommendation is the primary reason individuals receive their tests. So the dilemma that we face is the different trajectories of life expectancy, which make decision-making more difficult for clinicians, patients, and healthcare institutions, particularly for those clinicians who do not regularly work with older adults and that do not consider the factors of life expectancy, functional status that I've mentioned earlier. So that clinicians, this last point I wish to make here is that clinicians are unaccustomed to telling people that they have something they've relied on for decades they no longer need. There's been a lot of pushback. So who contributes to overscreening and how do we interrupt this routinized behavior? This schematic shows the main healthcare system players. Starting at the top here, we know that patients believe that more medical care is better, so they continue screening out of habit. And this sentiment is reinforced with years of unbalanced public health messages that are focused on the benefits of mammography and screening and the ever-popular war on cancer. Moving to the right, we know that clinicians' recommendation, as I just mentioned, is the strongest driver of screening. Clinicians emphasize the benefits and infrequently mention the harms of screening to patients. We've heard from studies, from qualitative studies, that clinicians feel uncomfortable talking about stopping screening, fearing a negative impact on the clinician-patient relationship. In the next box, we know that we have a fragmented series of healthcare institutions where individuals visit multiple providers with multiple specialties. And as a result, there is a wide variation in service delivery, multiple delivery systems, and test duplication. And lastly, in the last box, we know that screening is reinforced through a culture of financial rewards from the insurers and policymakers. In fact, insurance claims rarely provide a distinction between appropriate and inappropriate screening, so it's very difficult for us to go and analyze the data. I focused on this last slide because this FOA focuses on multi-level interventions. And by that, we mean that applicants need to intervene at 2 or more levels of individuals, clinical teams, healthcare institutions, and/or community settings, and measure outcomes at 3 or more of these levels. The domains within the multiple levels are as follows: individuals, patients, caregivers, family members, or providers. A clinical team comprises of 2 or more providers, including specialty and primary care, as well as support staff. Healthcare institutions, I've had a lot of questions about this. This involves the collection of primary and specialty care providers and their support staff, medical facilities, and organizational structures. And the community setting are the environments where the process of delivering healthcare reflects the approaches followed by providers whose primary responsibilities are patient care. And a good example are the federally qualified healthcare centers. To examine the complexity of the healthcare system, I'm showing this schematic by Rouse and colleagues. And on the bottom level, you can see patients and caregivers. The layer above are providers and clinical teams. And above, on the top layer, above the providers and clinical teams are the delivery options, and then above that are the healthcare institutions. What I wanted to focus on here is we're trying to figure out a good way to describe how to, when you focus your study, to consider the important connections between the levels, that it's the individuals who connect to the various parts of the healthcare system, for example, as in between or interlevel, or within with interlevel. Interlevel may be healthcare service delivery and the information flow between levels, such as a network of independent and potentially unconnected primary or specialty care physicians, or with an intra-service delivery within levels, such as connected providers working within clinic teams. So that the point I want to make here is that any change at any level will have consequences at multiple levels. So all multi-level analyses need to consider these interactions as reflected in the understanding of on the impact of mediators and moderators that result in timely and appropriate follow-up, treatment, delay, or no testing received at all. The research submitted to this FOA should focus on hypothesis-driven questions that develop and test multi-level interventions to reduce overscreening among older adults for breast, cervical, or colorectal cancers. For this announcement, the aims are to identify the modifiable drivers of overscreening amongst our older population, the clinicians, and the healthcare institutions, to develop and test interventions to improve overscreening outcomes for older adults, and 3, to support large-scale implementation of effective programs and practices that reduce overscreening amongst older adults. To reduce overscreening, we suggest multiple strategies that can be accomplished by either the R21 mechanism or the R01 mechanism. If you're considering an R01 mechanism, you would be conducting a pilot study where there would be smaller studies, and these studies would understand the drivers of overscreening and would lay the groundwork for conducting interventions to reduce overscreening in older adults. The R01 mechanisms would conduct larger studies and address the determinants of overscreening at multiple levels of the healthcare system, and then would test these interventions in the different healthcare systems. So to delve in a little bit closer with these different mechanisms, the R21 mechanism are ideal to, as I mentioned, to facilitate pilot work and to inform larger studies and interventions. And these studies might include mixed methods to describe the individual values or health goals, or emphasize organizational determinants to encourage ways to reduce overscreening. Interventions might focus on the clinician-patient strategies to improve communication in the face of uncertainty. The R01 studies would support experimental, quasi-experimental designs and large observational studies that develop and test multi-level factors that drive overscreening. These studies may test prognostic indicators to assess who should not be screened. We may have resulting electronic data that could be integrated into existing EHRs, and interventions to decrease overscreening might concentrate on system-level incentives or innovative reminders between different clinical specialties. All studies must be conducted in a healthcare setting and involve at least 2 levels of the healthcare system, as I described earlier. As mentioned in the funding announcement, the potential topics to improve overscreening can be broken down into 3 areas: utilization, adherence, and delivery. Underneath utilization, we may look at, or you may look at, communication strategies between adults, caregivers, if they're needed, providers and or healthcare teams that embrace or inhibit overscreening. Underneath adherence, clinician interventions that are effective at decreasing or discontinuing, such as de-adopting overscreening amongst older adults, and how can these interventions be integrated into healthcare practice. With the delivery, we're interested in looking at real-time virtual consults between primary and multidisciplinary specialty care, and how it can be implemented with complex adults and or caregivers in community settings to utilize provider time, reduce duplication referrals, and unnecessary screening tests. There's a much more exhaustive list of areas that we're interested in the funding announcement, so please take a look there. So study outcomes. The primary outcome would be to decrease the proportion of older adults who are overscreened, and you would measure your outcomes based on the healthcare delivery settings at 2 or more levels and account for the interactions that occur between the levels. So I'm kind of getting towards the end of my talk, and I want to say that there's two program announcements. For the R21, it's PA 17109, and for the R01, it's PA 17110. We are on the general CSR, general study section, and submission date, the earliest submission date was this past May, so we're getting ready to review the first batch of applications that came in. We do not need a letter of intent. So as I said, the earliest start date applies to the standard NIH start dates, and the expiration is January 18, 2020. But I can't stress enough that you need to start the process early, allow time to register in the system for award management, ERA Commons, and grants.gov. And I'll do a shout out here for something that is very much on the horizon that we're dealing with as staff, and that's the change in the terminology for clinical trials. And I'll just say really briefly that they're optional for this study. So resources, today's webinar and a series of frequently asked questions will be posted on our website in about the beginning of October. If you have specific questions, I really encourage you to reach out and contact me directly. My contact information, if you don't take it down today, is in the FOA. If you feel that there are other staff within our program who may be more appropriate, please use our website and identify the individual. We all work very closely together here. And a plug, to stay connected with us, subscribe to our email listserv using the link on our homepage, and of course follow us on Twitter. We have an official program Twitter, and I have a Twitter account that's not official, so you may also follow me. So I think this portion we're ready for questions. And I'm just going to talk to my team here to see if questions have come in. There's a specific question here, and I'll read it to you. You mentioned hypothesis-driven aims for this PA. Is prediction of healthcare practices eligible? I'm not sure what you mean by prediction of healthcare practices, but, please, if you want to use healthcare practices, yes. Second question is, do you encourage the use of claims and or EHR data for the R21? Yes, if it leads to forming an intervention and if it is novel and developmental work, please go ahead and use this data. The third question is, what standing review panels would be appropriate for this PA? Depending on your focus, I think a natural home would be HSOD. And I'll just mention that we had a meeting yesterday with the head of the Center for Scientific Review, and we talked about several of the panels that we might use for this program announcement. What program can do is, if there is not the essential expertise on the panel, then we can make recommendations to fill the gap, so that if we don't have aging people but we have health services people, we can make the recommendations. And the SROs welcome this information. The other thing that I would say to you is, take a look at a couple of other panels and see if you think they may be a better fit for you, such as nursing. I think a disadvantage with nursing is that I heard that they received over 200 applications this last round. So I probably wouldn't recommend it. There's another question that's come in. Does the study have to address overscreening in all 3 cancers? No, but if you're doing an R01 that you think you're able to address all 3 cancers and it makes conceptual and intellectual and scientific sense to do so, and it fits within a budget, go ahead and do that. A question is, a major problem with colonoscopy is bringing patients back for repeat exams prior to the recommended date, i.e., this is for routine screening. Would an intervention to address that be responsive? Yes, and I would need to talk to the person who asked that question because I'm sure there are some specifics that we could talk about in general. I encourage you to send me your specific aims page or list of questions before we talk so that I can formulate my thoughts as well. A question that's come in was, do R21s need to propose a 2-arm randomized trial? Well, R21s may, but they're not required to propose a 2-armed RCT. And as a reminder, the R21 mechanism is an exploratory mechanism. And so these proposals would address acceptability and feasibility. Rather, it would be more appropriate to see a 2-armed randomized trial with an R01. I'm just reading the questions that came in. Okay, this is a critical question. You mentioned the use of alternate definitions to old, but also referred to the USPSTF Guidelines. Must outcomes only be tied to guidelines, i.e. overscreening and using breast for over 75? I would say that's your primary outcome. Your secondary outcome could be expected life expectancy or some other measure. But the primary outcome needs to be tied to the USPSTF guidelines. Another question, you did not mention underserved populations. Is this a priority? Yes, we know that older adults from varying disadvantaged socioeconomic incomes and racial ethnic groups are probably more likely underscreened than overscreened. However, if you have a population of minority older adults, we would very much welcome it. We'd be very interested in it. Can you comment on the role of preliminary data for the R21 mechanism? R21 mechanisms are not required to have preliminary data. So you do not need to send it in, and this is also mentioned during the review. There's one more general question. Are new applicants who have not had prior NIH funding before encouraged to apply? I would say yes. We welcome applicants who are both new and early-stage investigators or investigators who are switching fields. However, if you're new to the NIH process, we strongly encourage you to consider working with someone who has experience with NIH grants and the NIH process, and particularly to find somebody at your institution. And also, for everybody, I encourage you to reach out and to contact me or contact one of our scientific program directors before you submit, and to discuss both your application and the study section. So I think, unless there's any more burning questions that has come in, that seems to be about all the questions. If you have additional questions, then I would be really happy if you would email them, and what we will do in about a week, we will put them, or at the end of the month, we will put them up on the web with the webinar and develop a series of FAQs. A lot of the questions that we did receive were specific to individual proposals, and this is where you need to reach out to me directly. Before I sign off on this webinar, I'd like to really thank the group of people who have been very supportive and who made this webinar possible: Jennifer Leidenberger, Genevieve Grimes, Alyssa Grauman, and Sharon McCarthy. And a hearty thank you to everybody. Thank you for joining us this afternoon.